CIHI is an independent, not-for-profit organization. Our mandate is to accelerate improvements in health systems performance and in population health. We do this through our work on data standards, analysis and reporting, and building capacity for clients across Canada to use data and information. In today's session, I'll start off with how to identify patients experiencing homelessness in hospital data, and I'll talk about some recent improvements in the quality of the information. Then I'll turn it over to Lucie for her to speak about the validation studies for case definitions of homelessness. Next, I'll provide some key findings from CIHI's report called Homelessness and Hospital Use, in which we looked at the health utilization patterns and demographic characteristics of patients experiencing homelessness. And finally, Lucie will speak about some examples of interventions in Canada and best practices for using identifiers of homelessness. Homelessness is an issue affecting communities across Canada. Studies coordinated by the federal government have shown that prevalence is increasing. According to the most recent government report, homelessness increased by 20% in the span of just a few years. People experiencing homelessness often have complex health needs and experience challenges that contribute to their poor health outcomes, including a much lower life expectancy than the general population. They also experience barriers to accessing healthcare services, including primary health care, and this may be why they rely on hospitals more frequently than other people. CIHI's analyses found that they almost always entered the hospital through the emergency department. Using health administrative data, there's an opportunity to use these routinely collected data to better understand the healthcare needs of this population and to tailor programs and services to better meet their healthcare needs. Before we present our work, we'd like to ask the audience a question about work done within your own organization. And now we'll have a poll that will come up just shortly for you to respond to. So the question is, has your organization conducted analyses to understand the healthcare needs of people experiencing homelessness? I see that people are still responding, so I'll give it a little more time. Okay, great. I see that we now have 123 responses. So approximately 45% saying yes, your organization has conducted analyses, and approximately 55% saying no. So thank you for participating in the poll. It's very interesting to see that many of you already have done some analyses in this area, and I hope that our presentation will further be helpful. Thank you, Tasha, for helping us with the poll. Now I'd like to talk about identifying patients experiencing homelessness in hospital data. In hospital data, we use the ICD-10-CA code Z59.0, referring to homelessness. The ICD-10-CA is a classification system that was developed by the World Health Organization, and CIHI has a major role in enhancing it for Canadian data needs. In CIHI documents and reference manuals like the Canadian Coding Standards, which are used in hospitals across Canada, we reference the definition of homelessness that was published by the Canadian Observatory on Homelessness. According to this definition, homelessness refers to a wide range of living situations, including temporary accommodations. This may include, for example, motels and living with friends and family, without prospects of secure housing. There are two steps that need to happen in order for this code, Z 59.0, to appear in the data that is managed at CIHI. The first is that hospital staff, this could be doctors, nurses, other people working within the hospital setting, allied health professionals, collect and document patients' housing information in health records. And the second step is that a hospital coder or a health information management professional assigns the code when preparing the data abstract that is eventually submitted to CIHI. Hospital staff may not sometimes ask about patients' living and housing situation in enough detail, or they may not ask in enough depth. And this is one reason why information about a patient's homelessness may be missed in the hospital record. And this becomes important when we further talk about the quality of the data. There have been some changes over time in the terms of the status of this ICD-10-CA code Z59.0. Prior to Z 2019, it was optional for coding, and we saw relatively little use of it in the data that we manage in CIHI. With consultation from members of government in provinces and territories, we heard that there was an agreement that it was important to have more comprehensive information about patients experiencing homelessness. And with this feedback, in 2018, Code Z59.0 has become mandatory to record. And what this means is, in the second step that I mentioned in the earlier slide, hospital coders are required to add this code to the data if they find in the hospital record evidence that the patient is experiencing homelessness. Over time, this coding mandate has evolved slightly. There was interest from hospital coders in terms of clarifying those scenarios in which homelessness should be added to the abstract. And in 2022, the definition was slightly expanded so that this code should be assigned if homelessness is on the record whenever documented. In comparison, it was slightly more narrow in 2018, where it was specified homeless on admission. And this coding mandate applies to the discharge abstract database and the National Ambulatory Care Reporting System, so both inpatient and ambulatory care data, including emergency departments. CIHI collaborated with Lucie Richard and Dr. Anna Durbin to publish a descriptive study of trends in coding homelessness for a 6-year period, 3 years before the coding mandate and 3 years after the mandate. Unit of analysis was the episode of care. We selected records with ICD-10-CA code Z59.0 in any diagnosis field, and some records were excluded, such as those without a valid health card number. We published this study in CMAG Open in 2023, and you can find the full details and additional analyses there. And we'll be posting all the relevant links for you in the chat. I'd like to share 2 main findings from this study about trends today. This graph shows the number and frequency of hospitalizations over the 6-year period, and the bars represent quarters of the fiscal year. What we see is that when the coding mandate was implemented, indicated by the purple dashed line at the beginning of fiscal year 2018, there was a sharp increase in the number and proportion of records that included Z59.0 homelessness. Between fiscal year 2017 and the first year that the coding mandate was implemented, there was an 84% increase in the recording of this code. The second main finding I would like to share is that there was provincial variation in the uptake of Z59.0. Similar to the previous graph, we have a purple dashed line showing when the coding mandate was implemented at the beginning of fiscal year 2018. And as an example of provincial variation, we can compare the top 2 lines in the graph corresponding to British Columbia and Alberta. For Alberta, as soon as the coding mandate was implemented, there was a very sharp increase in coding homelessness. In comparison, in BC's data, there was a less sharp increase. Although we do not know what portion of the increases were due to the coding mandate, it seems likely that it did have the intended effect, which was to promote increased consistency in recording homelessness using Z 59.0. In this section, we saw that the recording of homelessness using the required code increased after the coding mandate, which supports better data for health system planning and research. As well, there was substantial variability between the provinces in the uptake of the Z 59.0 coding. And I'll now turn it over to Lucie to present about the validation studies.
Thanks, Diana. Just hang on one second. I'm going to share my screen here. All right. Hi, everyone. My role today for this presentation is really just to provide a bit of a deeper dive into data quality. I'm not affiliated with CIHI myself in any way. I'm just a researcher that's part of a larger team out of St. Michael's Hospital in Toronto, and we're focused on understanding the health and healthcare needs of people experiencing homelessness. We also create and evaluate hospital and community-based interventions to, we hope, help fill the gaps that we identify. And health administrative data are really important in our work, so we do have a vested interest in having good quality homelessness identification. But one thing that is true for all admin data, and this is probably obvious to everyone in this audience already, is that although administrative data have great breadth and high potential for population or quasi-population level work, they are by their nature imperfect because they're not designed or collected with research in mind. So when you look at this excellent figure that I just pasted from earlier, you could have plenty of reasonable questions about the quality of these data. For example, are the green bars exclusively made up of people who are homeless? If not, how many people are being misclassified? Did the mandate increase numbers of actually homeless people, or did it increase misclassification or some combination of the two? And conversely, how many folks are still being missed post-mandate? Are there certain subgroups of people that tend to be identified or misidentified? In other words, if you're not identifying everyone, which is possible, are you capturing a representative group? So to get at this information, you need to conduct validation work. Validations are a type of study where you compare a known truth, in this case, housing status, against you would find it in the administrative data. And validations require very high quality data to be used as a reference for this reason. So to make sure that the known truth you're comparing is in fact truth. In this case, you're also comparing a status that is changeable. So ideally, you'd have research data collected prospectively over time from a sample that is representative of the group you're interested in. For homelessness, both the prospective collection and getting a representative sample is a little extra complicated to achieve for a bunch of reasons that are out of scope for today. But I happen to be involved in 2 validation studies looking at identifiers of homelessness within CIHI managed data, one right before this mandate came into play and another a few years afterwards. I believe Diana will be posting the citations for those publications in the chat in case anyone's interested in looking at them in more depth. Both studies used very high quality longitudinal cohort studies from representative samples as our gold standard. So we are in the unique position today of being able to talk about validity for both sides of this graph, and by extension, inferring something about the impact of the mandate. I'm going to assume that despite the familiarity in this audience with admin data, that maybe not everyone is familiar necessarily with validation. So for the benefit of those folks, and also for anyone who likes or prefers to learn visually like I do, I'm going to explain some of the key validation pieces through a figure first. Imagine that this lime green area here represents the universe of all people experiencing homelessness, whether or not they use healthcare. Now, imagine that this purplish box here represents everyone with healthcare flagged with Z 59.0 or some other homelessness indicator. And just as a quick sidebar, in our studies, we considered not just ICD-10 codes Z 59.0, but also other variables that can indicate homelessness. Like, for example, in NACRS, we have a residence type, which you have as a possible answer homeless shelter. anyway, the overlap between the green and the purple boxes and what's left behind in the non-overlapping portions, these are what represent sensitivity, which is the overlapping zone divided by the green box, and the positive predictive value, which is the overlapping zone divided by the purple box. And we're going to focus on those two characteristics for today. Pre-mandate, which is what you're seeing right now, the definition most equivalent to the one we decided was optimal in the post-mandated study had a sensitivity of about 25%, meaning that you could capture about 1 in 4 people who were homeless. It also had a positive predictive value of 51%, meaning that the indicators misclassified about half of the folks that were flagged, meaning, in other words, that the folks in this non-overlapping purple section weren't homeless. Post-mandate, with the same underlying population, you can see that the purple box has gotten much, much bigger. And this is what you saw earlier in that graph where you saw the big jump in coding in 2018. This much bigger purple box now covers a little over half of the green zone, giving us a now 53%-ish sensitivity. However, the portion of the purple box not overlapping also increased. So now we see that about 2 out of 3 people who are identified through these codes were not actually homeless. Now, this bigger non-overlapping area is not great news, obviously. One thing that I do want you to keep in mind about this non-overlapping purple zone, which we call false positives, is that almost 75% of them are from people with a documented history of homelessness. So it's not necessarily that the code isn't correct per se, it's more that it's quite insensitive to timing and is capturing tons of people who were but are no longer homeless. And there's a couple of explanations for why this is happening. The first is that patient records may not be properly, they may be getting improperly carried forward. For example, registration or triage from a prior visit being reused in later visits without verification. A second option is that we know history of homelessness is quite relevant to healthcare needs even after someone becomes housed. So it is likely that sometimes physicians or other healthcare staff are documenting the individual's history of homelessness as important context to their current healthcare needs. But the health information professional who codes from those charts don't have the latitude to distinguish between current versus past homelessness with the mandate. So they see homeless, they have to code. So that's validity kind of in a quick nutshell here. In the post-mandate study, which we'll mostly discuss from here onwards, we assessed a total of 42 different case definitions that were different on the basis of several factors, like which indicators we assessed or which databases we considered. In Ontario, where these validations occurred, we have access to CIHI managed databases like DAD, which is hospitalizations, NACRS for emergency department care, and also OMERS, which is specific to Ontario and includes psychiatric inpatient care. The best performing definition amongst those 42 options was any identifier within any of those 3 databases during or within 180 days of the housing episode. Although I have to say that Z59.0 made up the vast majority of what was identified post-mandate. So if you only have access to that for some reason, you could limit yourself to that code alone if you so wished. This definition had a sensitivity, as I said before, of about 53%, an almost perfect specificity, and a positive predictive value of 36%. This is within the universe of people experiencing homelessness, whether or not they even use healthcare. However, you might be interested in a different group. Perhaps you're more interested in patients experiencing homelessness, the folks who are using these healthcare and have the opportunity for having these identifiers. If you are interested in this group and you restrict to housing episodes with at least 1 eligible healthcare encounter within these databases, the same definition increases quite a bit in sensitivity. So now you're looking more at like 75% sensitivity. Meanwhile, the other validation characteristics remain pretty much the same. One thing that's important to note, especially for those of you who are coming from hospital organizations or other organizations who may not have access to all of these databases, or perhaps the ability to link between them, is that sensitivity does vary a lot by database. This wasn't the main focus of our study, but we did pull some database-specific results. So I've pasted a few here to illustrate the point. The inpatient sources, so DAD and OMERS, which would be equivalent to just DAD outside Ontario, by the way, had a sensitivity of about 18.5%, NACRS, the emergency data, by contrast, had a sensitivity of 50%. And the reason sensitivity varies so much is, again, this idea of the underlying population. Are we talking about people experiencing homelessness or patients? Although people experiencing homelessness do as a group use healthcare at a higher rate than the general population, the likelihood of someone being hospitalized, for example, is still much lower than other forms of healthcare. I'm pasting here some data from a separate study that we did using the same high quality cohort that talked about the 1 year healthcare utilization. Only a small minority amongst them had an acute inpatient healthcare encounter, and even fewer had psychiatric inpatient encounters, meaning that there are simply fewer opportunities to be identified from those sources. By contrast, almost 60% of the cohort had at least one emergency department visit within the year. So NACRS, again, gets more kicks at the can. And for this reason, it provides the bulk of the identification in the broader definition. Let's say you were just interested in the population of inpatients for some reason. You would then want to consider validity only amongst, people with housing homelessness where there's at least one inpatient healthcare encounter. If you do that, sensitivity in this case is more like 60%, which is about right compared to the rest of the validation results that we've pulled. Anyway, long story short, your population of interest is an important thing to think about when considering identifiers and their sensitivity. And this is, by the way, the chief reason we listed a definition that includes all availability databases as optimal. Finally, in the newer validation study, we took more care to compare housing episodes with correct and incorrect classification to see whether there were biases in who were being misclassified. The largest bias is one that's unfortunately inherent to the design, and it's actually so obvious I didn't put it in the slide. Folks who have less healthcare are less likely to be flagged, and people with more healthcare are more likely to be flagged. That's fairly obvious. Even so, aside from that, there are certain groups who were statistically more likely to be misclassified as homeless. So part of these false positives that we talked about earlier. These include youth and young adults under 30 years of age, people assigned male at birth, people who self-identified as white, and those who with substance use or mental health disorders. The flip side is also true. There are some folks who are significantly more likely to not be identified as homeless when they were in fact homeless, what we would call false negatives. These people include people assigned female at birth, people who self-identify as Black, recent immigrants to Canada, and folks with shorter episodes of homelessness. Some of these characteristics are also associated with fewer healthcare encounters, so it's possible that the healthcare frequency is partially explaining these associations, but I've also listed them here because we know that several of these groups also are less likely to disclose their status during healthcare for a variety of reasons. Everything else that we could measure was not significantly associated with misclassification. And I've noted a few notable examples where this is actually a good news story. So things like type of homelessness or self-identifying as an Indigenous person, these things are not associated with whether you're more or less likely to be classified correctly. So overall, the main takeaway about all these studies is that after 2018, up to 53% of people experiencing homelessness or 75% of patients are captured in CIHI managed databases post-mandate. And that's if you use all of the available CIHI sources for your region. Still, 25% of patients continue to not be captured despite the mandate. And 2/3 of the folks who are being flagged as homeless within CIHI's managed sources are not currently homeless. However, they are likely to have a history of homelessness. Before I hand things back to Diana, I'm just going to add two final little points, though. First, keep in mind that although we used extremely high quality data for both our validation studies, they were conducted in specific settings, and therefore they reflect the population and healthcare environments in those places. Our reference standards came from large urban centers in Ontario. So validity could look different in other provinces or territories, or in more rural settings where both homelessness and healthcare look pretty different. There are some ongoing studies about that will hopefully fill out our understanding of validity in those places. But for now, you can take this as a good first step. The second thing I want to mention is actually some quite recent news from CIHI that will impact validity again moving forward. After our most recent validation study came out, I spoke with Diana to learn about the process for requesting a change to coding standards, specifically to alter guidance to restrict use of code Z59.0 to current homelessness only to deal with those false positives. And she took this up for me, and it's now, as of last week, been included in a guidance document, which I will paste in just a moment. Hopefully, I expect that this will cause a decrease in the number of individuals being identified moving forward. But again, if you'll recall the visual from earlier, that non-overlapping purple box, it should decrease that portion, which is a good thing. Of course, I'll suppose we'll have to conduct a third validation to find that out, though. With that, back to you. Thanks, Diana.
Last year, CIHI released our second report about homelessness called Homelessness and Hospital Use. National level analyses highlight some of the kinds of information you can create at a more local level. For all of these analyses, we selected records that contained the mandatory code for homelessness. We found that compared to the national averages, patients experiencing homelessness stayed twice as long with double the costs. For example, the average length of stay for patients experiencing homelessness was 15.4 days compared to the national average of 8 days. These patients used hospital services for a variety of reasons, and for hospitalization, I'm only referring to inpatient stays here. The most common three most responsible diagnoses, or the main reasons for the stay, were substance use disorders, schizophrenic disorders, and cellulitis, which is a bacterial infection. Some other common reasons were pneumonia, COPD, heart failure, and type 2 diabetes. We also examined the demographic characteristics of these patients. We found that most patients were male, and most were adults between the ages of 20 and 59. With regard to the demographic data, we also explored how that profile would compare to the profile of people experiencing homelessness who are for which there are other data sources, which I've indicated here as non-hospital data sources. The first two, point-in-time counts and the National Shelter Study, are managed by a federal agency called Housing, Infrastructure and Communities Canada. And the third, Homelessness Counts, is a study that has been funded by the Public Health Agency of Canada, and it is co-led by Dr. Cheryl Forchuk and Dr. Richard Booth of the University of Western Ontario. So what we found when looking across all of these sources is that they were very similar in terms of the proportion who were men, so gender is collected in the non-hospital data sources, or males, as I spoke about in the hospital data. The age profile was somewhat similar, but there were some differences. The hospital data had a lower proportion of children and youth, and a higher proportion of adults age 65 and older. In the three national non-hospital data sources, they did collect information about Indigenous identity, and they found that across these sources, at least 31% of people experiencing homelessness identified as Indigenous peoples. Since 5% of people living in Canada identified as Indigenous peoples in the 2021 census, this highlights that Indigenous peoples are disproportionately affected by homelessness in Canada. For those of you who would like to use the hospital data, there are some data limitations that we'd like to mention. Well, we've spoken a bit already about the comprehensiveness or completeness, as well as the accuracy of identifying homelessness. Some patients may not identify themselves as experiencing homelessness out of concern for experiencing discrimination or for other reasons. Practices at the hospital level for asking about housing and other social determinants might vary among hospitals. Some hospitals may implement practices that would be better suited to gathering this information and making sure that it is transferred into the data, while others may not. And as we saw in the slide about the provincial variation, it is likely that there are practices that vary across provinces as well. Given these data limitations, comparisons among hospitals or geographic regions should be interpreted with caution. In terms of the trending, we did see that the data prior to 2018 is much less likely to have the Z59.0 code used because it was optional at that time. So we don't recommend including data prior to 2018 unless you're doing a study as such as the one I shown where we were specifically looking at the difference across those time periods. In the study that I presented, we did not have data about certain demographic characteristics such as race and Indigenous identity. More recently, as of 2022, hospitals can submit data about race and Indigenous identity on an optional basis. And I'll turn it back over to Lucie.
Thanks, Diana. Just 1 second once again to share my screen. Okie dokie. Okay, so for this final section, you guys are all presumably here because you want to better understand how you can use these indicators of homelessness to do work of some kind. Maybe you want to conduct a research study, maybe you want to evaluate a program you've started, or maybe you just want to provide justification for funding a new program. That one is increasingly common. You might also wonder if others even are using these indicators. In short, yes, people are using these indicators and increasingly so. You can see here that a lot of Ontario-based research and increasingly stuff outside of Ontario and Canada even has been surfacing. The use of codes of Z59.0 as a way of talking about healthcare for people experiencing homelessness has also seen an uptick in a lot of media because it's something hospitals can pull relatively easily. It's also something that's increasingly recognized in sort of general thinking that health and homelessness are super interconnected. And we're seeing more and more partnerships between healthcare providers and homeless serving organizations, which, speaking as someone on such a team, it's really nice to see. Many of the interventions here rely on data on some form. I'm going to provide 3 little buckets here of different types of interventions. So the first group here are programs that use the hospital encounter as an opportunity to improve outcomes after an encounter is over. So for example, at St. Mike's, where I'm affiliated, Navigator and the ED outreach programs exist and have been around for a long time. There's also the No Fixed Address program out of London. The second group are medical respite style programs, which are desperately needed since typical discharge and follow-up care planning doesn't work very well when the patient is homeless. A lot of things are assumed about follow-up care that just don't apply. And for that reason, it's a fairly significant number of people who are homeless, who are discharged, end up readmitted within a few months, often with deterioration of their condition or complications. Anyway, I've listed a few examples of these types of programs here, but the list is certainly not exhaustive and it's continuously growing. And finally, we're starting to see more and more hospital partnerships involved in providing long-term housing itself. Again, the examples below are not exhaustive, but all of these programs form basically a pipeline from hospital directly to housing. It's usually referral-based, but in the case of Dunn House in Toronto, the most recent of those initiatives, the hospital is actually using administrative data to identify its target tenants, since the strategy has been to divert the patients who have the highest frequency of healthcare use. With all that said, given everything I've said earlier about indicator quality, you might be a little squeamish about using it, and I wouldn't blame you. There are some uses of the indicators that aren't really, I wouldn't recommend them at any case, and it's worth being cautious to avoid situations where your analysis could cause biased results. This always matters, of course, but this matters especially here because we're talking about a population that is extremely marginalized and stigmatized. And biased results can cause real harm, especially in creating or perpetuating damaging stereotypes. I'm going to just list a few small guidelines here, but if ever you're in doubt, you're always welcome to reach out. I'm happy to discuss projects or think through approaches or pitfalls or whatever with you. The one thing that I wouldn't recommend off the hop is enumeration type efforts. Whether you're trying to enumerate the population overall or within a hospital. This also extends to enumeration adjacent efforts like estimating the proportion of a population that is homeless. I gave proportion of substance use of people with substance use disorder as an example, because you'll recall from earlier that in this particular case especially, there are characteristics like substance use that lead certain people to be more likely misclassified. But even then, overall, the data validity is just not there yet for enumeration purposes, even when you try to adjust your estimates for imperfect test characteristics. Cohort studies where you establish a sample with a certain exposure and follow them over time, or trend work where you compare rates over time, are generally okay, unless the outcome you're interested in is something like substance use again, which again, not recommended. The high rate of false positives are actually less of a concern in most cases here, because generally folks experiencing homelessness have higher rates of almost everything. So the consequence of the low positive predictive value is actually to attenuate your results. It diffuses or reduces your signal. And by that, I mean, if you were to identify a trend or a disparity in a given outcome, the result would be diffused somewhat or attenuated to the extent that the outcome is directly proportional to the importance of current homelessness. So as an example, if you're working on something like cold-related injuries, which we've looked at in the past, those results are likely to be quite attenuated results due to the presence of housed people with a history of homelessness amongst your homeless cohort. So if you do plan to do a cohort or a trend study, it's important to keep that in mind, but it's also important to do a couple of other things. Number one, you want to label your group correctly. These are not people experiencing homelessness. They're a blend of people experiencing homelessness and people with a history of homelessness. In past papers, we've labeled it as like people with a recent history of homelessness or something like that. If you want to be super pedantic, you can also say patients with a recent history of homelessness to really clarify that the folks you're identifying are those who use hospital-based healthcare. And finally, if you use these indicators to compare outcomes to a housed comparator group of some kind, you will want to make sure that your comparison group is pulled from the same pool of eligible people. For the simple reason that the homeless group requires at least one healthcare encounter where they have been flagged as homeless. You will want that the house group also requires at least an eligible healthcare encounter of some kind, of course, without the flag, in order to make it more of an apples to apples comparison. And that's all I've got with regards to that. So I'm going to pass it back to Diana to finish this off.
Thanks. So how can you access data that will allow you to use this information about homelessness? I'd like to highlight HDRN Canada's Data Access Support Hub, or DASH, which is a network of data centers that can provide access to detailed data from provinces and territories across Canada, provided appropriate approvals and agreements are in place. Depending on the nature of the work, DASH may direct you to work with the provinces and territories or pan-Canadian centers such as CIHI and Statistics Canada to obtain the data you need. They're a direct line of communication to multiple data centers across Canada. And there are benefits to working through the network. For example, some data centers may have detailed information to support your work, such as access to data from other sectors like education and immigration. If you have any questions, we recommend you reach out to dash@hdrn.ca.